One. Please start.
Yeah, just. Dinesh sir.
বলো।
জাস্ট আপনি চেক করে নিন, স্লাইড দেবো, আমাদের ব্রিফিংটা দেবো যে মুভ করছে কিনা, চেঞ্জ হচ্ছে কিনা, চেক করে নিন।
হ্যাঁ, আওয়াজটা ক্লিয়ার আছে না?
হ্যাঁ হ্যাঁ
দেখা যাচ্ছে ক্লিয়ার? স্লাইডস দেখা যাচ্ছে?
স্লাইডস আসছে স্যার, ইট ইজ লোডিং। কেন আপনার তো মানে নেটওয়ার্ক ইস্যু হয়। হ্যাঁ হ্যাঁ এসে গেছে স্যার, স্লাইড শো ভিউতে করুন।
একবারই হয়েছে রে, প্রত্যেকবার হয় না।
ঠিকবার সেটা আপনার হাতে থোড়াই আছে, সেটা নেটওয়ার্ক ইস্যু, আপনি থোড়াই।
এখন দেখ ফুল স্লাইড হচ্ছে?
একদম 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 ঠিক আছে।
ঠিক আছে,
তাহলে আমি ব্রিফিংটা দিয়ে স্টার্ট করছি মিটিংটা, ঠিক আছে?
আমি স্লাইড শেয়ারটা অফ করছি না, ঠিক আছে? থাক।
অফ করার দরকার নেই, থাকুক থাকুক।
চলো।
এক মিনিট।
Hello.
Abhishek.
Hello. Sir, good evening. Dinesh sir.
Yeah, Abhishek.
Yeah, good evening.
So Abhishek, sir is joining us in a couple of minutes. Sir is just about to reach his home. Sir, request me ki we start with Dinesh sir, and sir meanwhile sir will join.
Yeah, me sir will join, no problem.
Okay.
Good evening, sir. Dinesh sir, good evening.
Yeah, good evening. अभिषेक तुम्हारा आवाज सुना जाच्छे ना।
Okay, sorry. So good evening everyone. Presenting today is our privilege to welcome you all to this Buyer Eyesight meeting. Today we are conducting this meeting on DME and AMD, and today our speaker is Dr. Dinesh Shumta. Sir is a VR surgeon from Disha Eye Hospital. If I say sir is a very young and promising VR surgeon from Disha Eye Hospital, he has already experience with the many cases with many years, and he also the flag bearing of this institute with, if I say, the young faculty of this institute. And if I say about the our another speaker is Dr. Sudipto Das sir. Sir is associated with Netherlands and any other, and with other institute also. Sir is a very senior consultant and a VR surgeon, and also a national speaker. So today's topic of Dinesh sir is AMD, critical information from the clinician to enhance patient outcomes. So I'm requesting sir to start with your presentation. Now session hand over to Dinesh. Thank you.
So good evening everyone, and thanks Abhishek for the lovely introduction. So hope my slides are visible.
Yes sir, yes, your slide is visible, your video is also on. Everything is perfect.
Okay, so topic of my presentation is neovascular AMD, what the clinicians should know. So talking about the global prevalence of the AMD, the world population is approximately 8.2 billion people, and it is estimated that the number of the people with AMD is around 196 million, which is going to increase in 2040 by 288 million. So these estimates indicate the global burden of AMD, age-related macular degeneration. Coming to the symptoms, starting from the blurring of the central vision, then patient will complain about the visual distortion, just like the straight lines are appearing bent, distortion of the straight lines, then central scotoma, and overall the general haziness in the overall vision. So these symptoms of the AMD usually appear suddenly and worsen very rapidly. So the symptoms of the AMD have a very profound effect as it worsens. The patient sees a central black scotoma in front of the eyes. Coming to the stages of the AMD, early and intermediate AMD, we all know that there is a buildup of waste material that is called drusen under the retina. With early AMD, they typically few to no changes in the central vision, whereas in intermediate AMD, drusen are larger and cause changes to the central vision. Still, it is manageable, but coming to the late stages, either it is geographic atrophy, means atrophy of the macula, and the other form, which is more dangerous, is called neovascular wet AMD, and which often leading to rapidly loss of the central vision, which is our main topic. So the diagnosis of the AMD is multifactorial by the clinical examination of the retina with the help of the Amsler grid, vision chart. OCT is the most important tool in our hand, and also the fluorescent angiography, and nowadays ICG for the PCB is quite helpful. So if we talk about the AMD management, the one line is very important, that is the time lost is a vision loss. And our aim will be reduce the treatment burden while maintaining vision gains. So timely important is very important, and early diagnosis is very, very essential. It improves the clinic efficiency, and we should have a very good communication between the patients and the doctors to make the understand patients that this is something which we have to treat, and it will go with the time. So if it is left untreated, permanent loss of the vision can occur rapidly after the onset of the symptoms. As we all know, it is because of the age, so we cannot properly cure the disease, but we have to maintain it. So what are the factors drive key mechanisms behind the pathogenesis of the wet AMD? So this VEGF-A and PIGF act via VEGF receptors to promote vascular leakage and edema and inflammation and neovascularization. With the help of this picture, here we can see that the VEGF-A acts via the VEGF-1 receptor and VEGF-2 receptor, whereas the PIGF acts both directly via VEGF-1 receptor and indirectly by VEGF-2 receptor by displacing VEGF-A from the VEGF-1 receptor. And the heterodimers of the VEGF-A and PIGF can induce and activate both of the receptors. So this axis activation of VEGF-1 and VEGF-2 receptor can result in increased vascular leakage and overall cause pathological neovascularization. Aflibercept is a globally available anti-VEGF agent that targets multiple mediators of the retinal disease. We all know that there are lots of the molecule in the market like brolucizumab, ranibizumab, faricimab and all, but mainly the molecules only target VEGF-A. Whereas aflibercept is a molecule which targets all those VEGF-A, VEGF-B or PIGF. Because if VEGF-A is completely blocked, as happens with the other molecules, VEGF-B and PIGF still able to bind the receptors and therefore contribute to downstream pathological effects, which is not possible with aflibercept molecule, as it have multiple targets. So these are the molecules which are currently available and approved anti-VEGF agents like aflibercept, brolu, rani, and faricimab. If we can see about the human half-life in days, aflibercept have the maximum around 9 to 11, whereas rest of have the lower than the aflibercept. And if we can see the number of the targets, aflibercept have multiple targets, 4 targets, whereas maximum others have the single target, whereas faricimab have the dual target. So coming as a aflibercept as a choice of anti-VEGF in wet AMD, we'll talk about the wet AMD and we'll talk about the PCB. Coming first in the wet AMD, we'll talk about the RCT and the real world experience. So talking about the RCT, we all know that the Altair is a very quite famous study. It is a multi-center randomized open label phase 4 study in treatment naive patients with neovascular AMD. Total number of the patients is 247. And this data from the Altair study support the efficacy and durability of the aflibercept 2 mg in patients with neovascular AMD. Here we can see with this data that the mean change in BCVA from baseline and injection number at week 96. Here we can see in the 2-week treat and extend regimen arm, only the 10.4 injections were used in till week 96, whereas the change in BCVA was 7.6, and the proportion of the patients at Q16 intervals at the final visit, that is at the week 96, were more than 40%, that is 41.5%, which is our actually the aim to increase the treatment interval. Altair study, vision gains which were achieved in year 1, here we can see in the graph is near about 2-week adjustment group is near about 9 letters, where we maintain to week 96 near about the second year with few than 4 injections in the year 2. So in the year 1, 9 letters has been achieved, which is maintained till the second year around 7.6 liter with hardly less than 4 injections in the second year in both of the treatment arm, whether it is 2-week or whether it is 4-week arm. Here we can see with this graph. So in Altair study, up to 96.2% of the patients were extended to Q16. Mark my words, Q16, which is very, very significant, and maintain this interval to week 96 with aflibercept in both of the arms, which is very significant and very important. Aflibercept can achieve vision gains that are maintained in the long term in neovascular AMD. Here we can see in the V1 study and the continuation of the V1 study, here we can see that in the week 52, around 10.4 letters of BCVA change were seen, and in the week 96, it is around plus 10.2, and this study has been continued as the name of the range study, and here we can see that at the week 212, that is around 4 years, around plus 7.1 letters were maintained. So vision gains with aflibercept maintained through 4 to 5 years with continued proactive dosing as per study protocol. A study from the FRB, fight retinal blindness, registry showed that a treat and extend achieved good vision gains with a reduction in treatment burden in the second year. So here we can see that initially it is 61.4 liters of the change in BCVA, and in the second year here we can see around 67.4 liters, around more than 6 liters from the baseline, and the mean number of the injections over the 2 years were hardly at 13.6. By the month, second year 24 month, here we can see that the 24% of the eyes were being treated at an interval of 12 weeks and beyond, which is very much important. Other study from Lukic et al. 2020, a study from the Moorfields, demonstrated that the vision gains achieved with aflibercept 2Q8 in year 1 were maintained in the long term till year 4 with continued proactive treat and extend regimen dosing. So here with the graph here we can see that in the first year 7.8 letters gain were there from the baseline, which is maintained till fourth year plus 6.3 liters from the baseline. And by the month 24, 52.8% of the eyes were being treated at an interval of 12 weeks and beyond. So here we can see that in the real world experience, mostly 12 weeks interval is quite easily manageable with the help of the aflibercept. This is another study by Jaggi et al. In 2020. This study is a little bit different as there is an absence of the initial loading dose, and there they have been shown that the proactive treat and extend regimen with aflibercept led to long-term maintenance of the vision gains even with the absence of the loading dose. So in the first year, here we can see plus 11.8 liters, whereas in the fourth year here we can see plus 6.6 liters. And by the year 4, the median injection interval was around 11 weeks. And the most important point is that 35% of the patients met the exit criteria and terminated therapy after 2.6 years. So these real world patients with neovascular AMD can achieve outcomes which are comparable to those in the RCT with aflibercept. As we have discussed, RCT like V1 and Altair, and we have discussed about the real world experience like Moorfield, Jaggi and et al. Here we can see that in the RCT, 58% of the patients were maintained at Q12 interval, whereas in the real world experience, near about 53% of the patients were maintained at Q12 interval, which is very important and which is basically our primary aim. If we talk about the PCB, RCT and the real world experience, Here we can see that mainly the Asian populations are having the more this PCV around 22 to 61% compared with the others like South American, Caucasian. So Planet study is a very significant study in the PCV, and we all knows it is a prospective multi-center double mark SAM control study, clinical study with PCV across 62 centers. And here we have seen the efficacy of the aflibercept monotherapy, whereas it is compared with the aflibercept plus PDT. So there are basically 3 monthly loading dose has been given of aflibercept 2 milligram, and the patients were randomized into 2 arms. One is the aflibercept monotherapy, whereas it is other is aflibercept plus active PDT. So we here the change in the BCV and from the baseline and safety outcomes we have seen at the week 52, that is a primary endpoint, and at the week 96 study endpoint, here we have the different parameters. So with this graph, we can see that the aflibercept monotherapy resulted in vision gains of more than 10 liters from baseline at week 52. So here we can see that the blue one is the aflibercept monotherapy, whereas the yellow one is the aflibercept monotherapy plus PDT. Here we can see that the primary endpoint at week 52 is near about almost same 10.8 to 10.7 liters, whereas it is maintained till week 96 with the help of only with the aflibercept monotherapy compared to the aflibercept monotherapy plus PDT. In both of the treatment arms, more than 80% of the patients showed no evidence of the active polyps, whether it is week 52 or week 96. So in the right hand side with the bar chart here, we can see that the proportion of the patient with no evidence of active polyps is more than 80% in both of the arms, whereas in week 96, it is also the more than 80%. And for the kind information, I will mention that what you mean by the active polyp, that is no polyps in the ICGA or with polyps on ICGA but no fluid on the OCT. Whereas the proportion of the patients with complete polyp regression, here we can see with the left hand bar chart here aflibercept monotherapy compared to the aflibercept monotherapy with PDT in the week 96 is around 30%. So across the clinical trials and the clinical practice, proactive aflibercept monotherapy achieves clinically meaningful vision gains in patients with the PCV. So RCTs like View 2, Vault, Apollo, a Planet study, or with the real world studies, here we can see that the proactive aflibercept monotherapy achieve quite meaningful vision gains. If we talk about the complete polyp regression, it has been observed across clinical trials and the real world case series with aflibercept monotherapy only in PCV. Here we can see with the eyes with complete polyp regression, whether it is Planet study or whether it is Vault study or whether it is a Japanese case series. Here we can see that aflibercept monotherapy is quite efficient for polyp regression. And this variability in the polyp regression rates are likely due to differences in the polyp regression assessment criteria across the different studies. And if you talk about the ocular safety, there is no doubt that aflibercept or Eylea is the most safest drug out of all of the molecule in the market, because the chance of the retinal vasculitis or the occlusive vasculitis or anything IOI is very, very less with the Eylea if you compare with the other molecule like faricimab or brolucizumab. So this aflibercept 2 milligram efficacy and safety profile has been established across RCT and RV and is supported by over a decade of real world. As we all know that using more than 1 decade, more than 62 million doses, or more than 9 million patients of the year's exposure in more than 20 countries, all this we can know that aflibercept is quite very, very safe drug. So thanks for the patience hearing. Thank you.
Thank you so much, Dinesh sir. Thank you for your flawless and in-depth presentations. But for the time of interest, we are sir, for the time we are going to the next presentation actually.
Yeah.
As we are running bit late. So our next presenter, Dr. Sudipta Das, sir doesn't require or need my introductions. Sir is one of the eminent ear surgeon from Netralayam Hospital, and sir will take us through the with the presentation, translating research into practice in DME management. So over to you, sir.
Thank you, Rishikesh. Thank you, Dinesh.
Thank you, sir.
I think very nice
Thank you, sir.
presentation.
And good evening,
I
sir.
thought that you will be sharing few cases. Good evening, good evening. I thought that you'll be sharing some cases.
Sir, good evening, sir.
This is good evening, good evening. Before I start my presentation, I just wanted to ask Dinesh once. Dinesh,
Yes, sir.
will you put PDT because now dye is getting available. So do you think that in few of your cases you can plan of giving PDT, or you will continue with your anti-VEGF monotherapy?
Sir, some
I
of sir,
think
some of
I'll
the
share the slide before you. Yes, please, you can go ahead.
yes, sir. What I was thinking that in some of the recalcitrant cases actually, where even the change of the molecule is also not getting any significant outcome, PDT will be a good option, sir.
In those condition, you will prefer to do PDT
Yeah.
after doing some loading dose, or you will just uh, uh, মানে, or you will just feel ki that okay,
Sir, actually,
you can decide about once you feel that it's not getting much effect with loading
yes,
dose.
sir. Yes, sir. Yes, sir. So basically, we'll try to first of all
Am I
we'll try with
audible?
the one molecule. Yes, sir. Yes, sir. I think little bit of network issue, sir.
Yeah, sir, we can hear you. You are perfectly audible. I think this is a bandwidth issue, or maybe in between, but still, we can hear you clearly.
Hello. Sudipta, sir.
Okay. The slides are visible, right?
Yeah, your slides are
Slides.
visible. So, can you hear us, sir? Is it clear
The
for
slides are
you?
changing also.
No, sir, is in not in slide mode actually. The presentation is still is in beginning phase actually. It's not in slide mode. In
Rishikesh, if sir required this, ask
No,
our tech team to help out.
no. I think there's some network issue. Sir has already put it
Yeah.
in slide mode, but still in the screen it's not there actually.
Actually, I think I asked her to off the video. Actually, I think some network issue.
Yes. Now it
No,
is
I'm
in
not able to hear
slide
you.
mode, sir. Yeah.
No. I'm not that I can change, but can you see my slides now?
No, not no. Sir has left. I think this
I
problem
think
with
there is some
Sir.
network. I think there is some network issue. So ask her to off the video. I think so.
Sir is
This will be
rejoining.
helpful.
Sir is rejoining. I think issue might be short out. Otherwise, we have to told sir 2 hours.
Now is it coming?
Yeah,
Yeah.
is there, sir. So yeah,
Yeah. Now it's perfect. Sir.
perfect.
স্যার ভিডিওটা অফ করে দিন তাহলে ভালো নেটওয়ার্ক হবে
Video already offed. I put it off.
হ্যাঁ এখন আপনার ভয়েসটা ক্লিয়ার আছে স্যার
Okay. So now you can see the second slide also.
Yes.
Disclaimer. Okay. Thank you. So I think what Dinesh was highlighting, if we us continue that presentation with
Yes,
the
sir. Yes, sir.
limitations what we feel in clinical design and outcomes. So we have definitely few things in clinical trials which can limit the generalizability of results to the broader patient population, as patients in trials may not present this seen in practice. So it's quite obvious, and we have a lack of consciousness on the ideal treatment regime for DME with various approaches like monthly treat and extend or PRN regime, and results may not fully reflect real-world complexities of the disease and its management. So if we go through this current landscape of anti-VEGF therapy in DME management, starting from RISE and RIDE to the Yosemite, if you can see all these presentations, with all the anti-VEGFs, if you can see the aflibercept, the aflibercept treatment has been supported by evidence from robust clinical trials, starting from Vivid Vista, drca.net, where you can see on the right side in Vivid and Vista, if you see the aflibercept arm, definitely it has a very robust clinical and visual outcome compared to any other molecule. So these, keeping in mind, there is always a need for real-world evidence to complement data from RCTs and support treatment regimens. So we actually have a lot of RCTs. We have multiple data from there. Most of the data actually has shown that to be effective, definitely non-inferior. But how do we actually put it into our real-world practice? So because what actually is important, that this one actually can influence the patient impact. It can have a worldwide differences and the value of therapy. Now, endurance is a study where patients with a mean 3.5.
Sir, you are not audible, sir.
Data 5 year. Now I think it was.
Your slide so not.
Now is it audible?
Now it is audible. Sir. Now it's better.
Still change the pattern. Hope it's slightly better. Is it better now?
Yes, sir. Your voice is better, but the slide now it's
Yes,
coming.
yes.
Yes, sir.
So the endurance part. What? Just a minute. Just call to put. So the endurance patients from Vista maintained the visual gain. If you can see, and the number of injections at year 5, which was mean 3.4, this was very important. This study showed that definitely we can reduce the number of injections. Now coming to the next one, if you see aflibercept, these I think Apollon and Moorfields, Dinesh has already mentioned about the RCTs. But you have to keep in mind that all these real world studies also, which were actually a real world representation, had a 5 monthly loading doses. So this is very important. This probably in real world, this also doesn't happen. So you have to keep in mind that these injections, these patients actually had 5 monthly loading doses followed by the real world extension policy. Now, Draco is one where the meaningful vision gain or maintenance with aflibercept was there, regardless of the baseline vision. Here, more than 75% of patients, the diabetic retinopathy severity level also remained stable from baseline to month 12. And the BCVA change at month 12 in treatment naive patients was plus 2.5, which is around 12.2 letters. For those with baseline less than 70 letters, the mean BCVA change was plus 7.3 liters, which was quite significant when the visual acuity was less, which has been proved in multiple studies on aflibercept. This is the data from Moorfields Eye Hospital and the FRD registry. This one I think is already covered by Dinesh. I'm not going into detail of this. But here, the important thing is that poor baseline visual acuity is commonplace in up to 2/3 of patients in clinical practice. And if we see the adjusted mean change in visual acuity among these patients, where the mean vision was less than 68 liters, The adjusted mean visual acuity gain from baseline to month 12 in eyes with initial vision, which was less than 68 letters or 20/40 or words, was significantly higher in eyes with aflibercept than those receiving ranibizumab with a similar number of injections. So this is, I think, we don't have any doubt. Now, aflibercept was compared with dexamethasone implant for recalcitrant diabetic macular edema in pseudophakic eyes. 1 year outcome for this quasi-randomized data, I think, has come from Disha only. Here, both IVA and DEX provide similar visual and CMT improvement in recalcitrant DME. Intravitreal aflibercept leads to more than 3-line vision gains but requires more injections follow-up. So that is obvious while we compare with DEX implants. This also a second one, in the IGO task force, the diabetic macular edema treatment guidelines, where they have chosen intravitreal injections of anti-VEGF at the first line treatment for all treatment naive central involving diabetic macular edema, and multiple clinical trials have demonstrated that anti-VEGF therapy is more effective in improving vision in CIDME than macular laser treatment. Now, the most common reason for non-response of anti-VEGF therapy is due to inadequate treatment. As per the above protocol, in eyes with persistent DME, where the vision is less than 6/12, a different anti-VEGF may be considered. If the patient has been on bevacizumab, a switch to ranibizumab or aflibercept is recommended, or if on ranibizumab, a switch to aflibercept is advised. This was the one which was actually published in IGO in 2021. Now, international recommendations and guidelines recommend the first line use of aflibercept when the vision is less than 20/40. These, I think, has multiple society guidelines also, starting from the URETNA guidelines, from the EPVRS guidelines, the Canadian guidelines. So they have all agreed that if the vision is less, aflibercept is the drug of choice in treating central involving diabetic macular edema. Now, the
Sir, sorry to interrupt you. Sir, if you could switch on the camera now, but I think its network is okay right now. So because we need couple of photo with a screen with a image. So if you can switch on the camera.
So just for a few seconds, because as a part of compliance, we have to take some photos with
sure,
the
sure.
slide. Yes,
Sure.
No, with slide only, sir.
with slide on.
With slide only. Yes.
Now it's okay?
Yeah, it's okay. Perfect.
Okay. So
I think now onward you can go with your camera already also. There won't be any problem for that.
okay. So this was the meta-analysis reviewed evidence from major studies investigating the efficacy of anti-VEGF agents in diabetic macular edema. Here, systemic meta-analysis of RCTs providing a level 1 evidence-based review of anti-VEGF agents, where they included 24 studies, 6,000 patients with DME, and what they have shown that at year one, all efficacy outcomes significantly favored aflibercept over ranibizumab. Patients were approximately 30% more likely to gain more than 3 lines with aflibercept than with ranibizumab or bevacizumab. And for every 1,000 people treated with aflibercept, 92 fewer would gain 3 or more lines of visual acuity at year 1 if treated with ranibizumab. So there was a clear-cut guideline in this meta-analysis. Now, other meta-analysis suggest aflibercept is the most favorable treatment for treatment of diabetic macular edema. I think we have multiple studies on that. There was a PLOS one publication also for this. So where it was the most favorable one in terms of BCVA improvement and CMT reduction compared to other therapies in management of DME at 12 months. Now, international guidelines and recommendations suggest aflibercept when it is less than 25/40. This is, I think, quite clear now. Now, EURETNA Asian diabetes, I'm not going into details of this. And because systemic review or meta-analysis, actually, these are all level 1, highest, we call it highest level of evidence compared to individual RCTs. So this meta-analysis definitely in evidence-based practice, in best practice pyramid, this definitely has a role in thinking or in considering the drug in treating diabetic macular edema. So this is being recognized as a standard of care in DME and is being used in 4 DRCR network protocol. You can go through these protocols A, B, the protocol V, protocol W, protocol AC, and protocol T. Protocol T, I think we are all aware of. Protocol AB was mostly for PDR. Protocol W was actually seeing the management of to reduce the risk of vision threatening. So it was also morely in the PDR range. Vitamin Protocol V was in patients of central involvement DME, and Protocol AC was on randomized trial on aflibercept versus intravenous bevacizumab. So I think out of this, Protocol T and Protocol W is important for us. Protocol T we are all aware of. Now, because of that, we have a practice where we follow different regime for any medications. We can start with loading and PRN. I think this was one we used to follow. Probably Dinesh also will agree. When we have started our practice, we used to give one single injection and then give injection as and when required. A better one is probably 3 loading followed by PRN, but diabetic retinopathy severity regression is least noticed here. Fixed dosing, here definitely there is an increased treatment burden, just like RCTs. 5 loading and bi-monthly is a recommendation for aflibercept. There is a superior visual anatomical outcome. Disease severity also is regressed, and treatment burden is lower than fixed dosing but higher than PRN, or 1 plus PRN or 3 plus PRN. And loading and treat and extend, I think, is idealized. That probably this is the one we should follow. Optical treatment, optimal treatment burden, their severity also reduced, and it is definitely the burden is lower than fixed dosing and 5 loading plus bi-monthly dosing, but higher than PRN in any format. So this is probably a thing where a lot of people follow this loading. I think most of the people probably still follow 3 loading and PRN in most of their clinical practice in most of their patients. Maybe few of them follow a loading and a modified treat and extend or treat and observe. Now I'll go through few cases where I'll show that where aflibercept was really helpful in treating this type of group. Now naive patients, most of the time, this patient has a 624 N12, 612 N8, 62-year male, cataract, diabetic, hypertensive, and these patients were actually having PDR and status post PRP. Now this was the edema. Right eye was having 618, left eye has 6/12 N8 vision. So we started treating this patient right eye with loading aflibercept, and this was after 2 injections, 6/9 and 6, and after 2 months post third injection aflibercept, it was 6/9 and 6. You can see certain persistent intraretinal cysts definitely reduced than before. Not much of thickening. 312 left eye is doing well. So this patient actually benefited with aflibercept, and definitely we probably will continue following up this patient. Try to follow extension or sometimes PRN. Now, if we treat very early and do an intensive therapy, which actually can achieve RCT-like vision gain in real-world patients, receiving more than 7 injection in year 1. Now, that is one crux, that giving more than 7 injection is in year 1. And this is the Moorfields and Apollon, where they have seen 7.1 injection and 7.6 injections can have a vision gain of plus 11.2 plus 6.5 letters. Both of the studies, as I was mentioning, had 5 initial monthly injection. So if you after 5 months, so from 6 months to 12 months, there are around 2 injections. So this is one thing which I have to keep in mind. But these 5 monthly initial doses were not administered during the study eyes, where these are the studies where they have not given 5 initial injections. These are Sivala et al. And Karn et al. And you can see the change in these patients, the reduced number of vision gain compared to this Moorfields and Apollo. Second case, 53-year female, diabetic, lipid lowering agents, NPDR, CME, left eye complicated cataract, recent control of diabetes. Now this was the right eye, 6/36. I started giving aflibercept on this patient. This was 6/24. You can see reduction. The exudation, the inferior exudation definitely is reducing. Superior is persistent. 6/12, 6/9, 3 injections, 16 weeks, 20 weeks. I got a recurrence, but somehow this exudation part actually has significantly reduced in this patient. 6/24 was the recurrence and the vision deterioration after that. We give injection 6 months, 6/9, 8 months, 6/9. So this after 8 months, this eye looked really normal. Now, right eye at 1 year, we had a recurrence again, 6/18, injection aflibercept, 6/9 again, 1 year, 5 months. So it was almost around 4 to 5 months. So it was almost like 4 to 5 months was giving a PRN injection. At 2 years, And this was again, but there was slight amount of fluid persistent, vision was maintaining 6/9. Now, if we continue, this 5-year outcomes of protocol T extension study highlight the need of proactive extended dosing to maintain initial vision gains while reducing treatment burden. We probably try to follow, because you can see the initial vision gain here to almost around 14 liters with this year 2 to year 5, where you are trying to have a extended dosing. You can see the later gains are definitely not that significant, but definitely it's not less. So it's almost like a slow plateau being maintained at year 5. Now, patients received a median of 12 visits and 4 injections over 3 years. This is one thing we have to keep in mind, that number of injections were definitely less compared to what we used to do. So this is one very important thing. The loss of vision may be a consequence of under treatment or inadequate follow, because very minimal number of injections in 3 years. Endurance also, I think we have already discussed about that. Coming to the third case, 60-year-old male, early nephropathy, NPDR, right eye hard exudate plaque at macula, status post injection ranibizumab biosimilar, left eye had a CME. Now this is the right eye which had exudation, subfoveal plaque, not improving much, vision 5/60 and 24. We can't give much hope to this patient, probably try to maintain the vision. This patient had injection ranibizumab in the past. Both eye had status post focal laser for the perifoveal and the perimacular microaneurysm, and both I had PRP later for PDR. This was the picture in the right eye. Again, subfoveal exudate, slight other edemas have reduced. Vision has not improved significantly. But this is the other eye, the better eye, which had 6/9, had some focal laser in the past because of this arsenase in the paramacular area. 6/12 injection aflibercept. When I have started giving this patient, there was a small NSD and a retinal thickening, more of the outer retinal edema. This was after 3 injections. NSD was still there. Vision improved to 6/12. The sarcinians have reduced, and after that it improved to 6/6. It took time after 3 injections for the NSD to go. This patient actually had a PDR, vitreous hemorrhage, wear surgery. I prefer to give aflibercept in all these patients where I am not keen to switch to dexamethasone. 6/12. This is a vitrectomized eye now. On injection aflibercept, edemas recurrence 6/9 with aflibercept, slight amount of intraretinal fluid 6/9. IRF is persistent, vision is maintaining, probably will continue the same. Fourth case, 58-year-old female, pseudophakic, NPDR, left eye CME 6/6 and 6, and left eye at 6/24 and 24. This is the left eye. We started giving aflibercept for this patient. 6/12 part, 6/9 part, 6/6 part. This was 4 injections, and 7 months after 4 injections, it improved to 6/6. And you can see the disappearance of this exudation also. And after 1 year, 6/12, there is a recurrence. So after 7 months, the recurrence was at 1 year, so almost around 5 months, 20 weeks, 6/12. We gave injection 6 weeks, 6/9. Again, after 12 weeks, aflibercept. So it was maintaining, though the edema was slightly persistent in the left eye. This patient was systemically not very well after that. This was the right eye, 6/12. I started giving injection aflibercept 6 weeks, 6/9, 12 weeks, 6/9. So a lot of times we could maintain some amount of vision. Very difficult to decide whether to change because of this persistent fluid. I usually prefer to wait when the patients are actually maintaining significantly good amount of vision and systemic control is not very good, probably more stress on those conditions rather than changing injections. Now, if we go through these cases, probably intensive loading dosage of aflibercept definitely has an age both in naive as well as recalcitrant DME patients. We have seen in these cases also, and I've shared that in real world cases, 4 to 5 injections in the first year holds promise. So I usually tell patients that probably will need around 5 injections in first year to stabilize in I'm treating a naive patient, and reasonable DM management and proper counseling is very important. This one I think already being discussed by Dinesh. The details of this. I'll summarize. Aflibercept achieve clinically meaningful vision when it's less than 20/40. Early intensive therapy definitely holds promise. Factors beyond vision, such as duration and control of diabetes, no way out. We have to treat the patients. A lot of times, real world time, we see that patients are either undertreated or under monitored. But aflibercept has definitely an age to others to safely reduce the treatment burden while improving and maintaining vision. It is the only bispecific VEGF fusion protein. It is very important. Early intensive therapy in DME, maximize vision gain in first year, that we have also seen in our cases in real world scenario. Proactive individualized dosing. So a lot of times we need to individualize depending upon the patient's response, his diabetic control, and the continuation of therapy. And aflibercept leads to visual and anatomical outcome in clinical. So, it is almost consistent with those therapeutic universities. Thank you so much for your patient hearing.
Thank you so much, sir. Thank you for your detailed, flawless, and an in-depth presentation. So now we'll move to the discussion part. So yeah, Dinesh sir, if you have any like any point to like highlight or maybe ask to sir
Yes,
to
great presentation, sir. Actually, sir, I'm also totally agree with you. When I have presented this slide, I think in the last year, this intensive treatment in DM is really, really helpful. If I'm not wrong, I am also practicing this. If the patient is quite affordable, patient can afford. I am also practicing this intensive treatment in DME, and yeah, I can see the changes compared to the loading dose of 3 and compared to the loading dose of 5. It's really helpful, actually.
I think Dinesh, absolutely I agree. And when the patient's initial vision is low, so there I think
Yes, sir.
aflibercept uniquely has a edge compared to any other injections. And the other big issue about aflibercept is safety. So,
Safety, sir.
giving loading dose 3 to 5 injections. So I think
Yes,
after three, we can decide whether you need, because it's not easy sometimes to give 5 loading. But,
5
uh,
loading.
so I usually counsel the patient for 3, and then after 2, depends upon the response of edema. If it is not improving, maintaining vision, probably I'll continue and try to extend.
But
But I
sir,
have
what after, but what after the loading dose, sir? You practice at T10 extra TNE
no,
or
see,
the PRNSF?
so most of the time, DME, we tell treat and extend, but most of the time it's probably observed and extend. So you treat whenever you get a slightest amount of edema.
Right.
But if I am whatever patients I have shared, if you can see that 16 to 20 weeks is the maximum window.
Yes, sir.
So the time if you have given loading, it is around 16 to 20. Beyond 20,
Four
most
to
of
five
the time,
months.
in 9 patients, they have a recurrence. So, so I usually prime the patients that probably will need injection after 16 weeks until unless you have a recurrence of edema before that.
Yes, sir. But in the one case, sir, you have shown very beautifully that even the after the VR surgery also,
Yes,
aflibercept is doing quite well.
that patient had a PDR, had a VR surgery. There was a window, there was a gap in between. Because of that, there was a big recurrence, but it responded well with aflibercept. Actually, that time, aflibercept was having that policy, that 1+2 policy was there.
1+2.
So the injections were still there with the patient, and patient was not keen to change. So I thought aflibercept, and he responded well, and so he continued aflibercept.
Yeah, because basically most of the doctors usually practice Ojudex only in this after
Yeah.
VR surgery actually.
That was one thing.
Sir, yes, yes. Sir, what about the PDT? I think PDT is coming. I think with the oral lab, it's not yet there actually. It's not in the market. I
They
think.
have just highlighted, but I'm not sure about the whole system, how it follow all the laser machines, the dye, the availability, the technician. I think it will take some time. But PDT in few cases of PCV, I think still uh, it holds good.
Mm.
But I PDT, the first and foremost for me will be CSR.
Yes, sir. I think yeah, that's only what I want to say. In the chronic CSI, we don't have any option.
Mm.
Actually, PDT will be of quite great help actually.
Chronic CSR, and in case of acute subfoveal CSR. If you
Subfoveal is no option actually.
probably you have only one option of going giving PDT.
So what about the recalcitrant cases, whether it is DME or in CNV? So what you practice in your daily routine, sir, in
See,
recalcitrant cases, sir?
usually I try to shift to the higher anti-VEGF. I
Yes.
usually switch because now we have so much option to anti-VEGF, then I would definitely prefer to switch to an higher anti. I will switch to steroids last until unless I have a specific
Yes.
patient or the patient had taken some steroid in the past or not being able to follow up, financial issues, I would still prefer to go for higher anti-VEGF. Now, in patients where we are getting some patients not responding to aflibercept as an anti-VEGF, whether this patient will be suitable to switch to higher dose or 8 milligram aflibercept is probably time can tell unless
Yes.
they start giving the injection. We start getting the injection. It is difficult to comment on that. But I would still prefer to go for higher anti-VEGF, and I would still prefer to go for loading dose because if you can see
Yes, sir.
see
Yeah.
our study with Faricimab, you can see the
Yes, sir.
two groups. I think the Dulalda was also part of their study, na? That
Yes.
when the two groups, the recalcitrant group as well as naive, the recalcitrant group also responded really well with loading. So if you switch, probably it has to be loading.
Sir, usually,
In CNVM, DME,
yes, CNVM. Yeah. What about DME? Yes, sir.
DME, I somehow feel that probably we should counsel for loading. We should counsel for loading.
Counsel.
Most of the time, if there is a response after fast injections, patients also
Yes.
comply. So until unless there are financial issues, you should always counsel for loading. And after fast injection, I usually pressurize more. I usually tell that you have shown significant response, so you should dry it down absolutely.
Go for now. But sir, if you talk about the recalcitrant or if you talk about the recurrent, so in the
Recurrent,
I'm talking about CNVM.
recurrency that those patients where we have done loading followed by recurrence of edema. So we have continued the same anti-VEGF.
Same
Because
anti-VEGF, no, sir?
recurrence is because you are not following treat and extend properly.
Treat and extend properly.
So, but the issue is that treat and extend, whatever said and done, it is not easy to practice in DME. If you are
Not
dry retina, you cannot give injections. Whoever
cannot give
does
injection.
probably is telling a lie.
So basically, recurrent CNVM is basically we should continue the same molecule. If it won't work, then we should switch actually. Otherwise, it's the same molecule we should continue.
I will continue same molecule. If there is a primary
Yeah.
response, I'm sure that I have not extended properly.
Not extended properly. Nice discussion, sir, actually.
No, I think very nice. And the only issue is that the cost factor is an issue. Most of the time, patients
Yeah, but
come with that only. But with newer insurance coverage part and everything, things are slightly better about loading. So loading has a definitive role.
definitely important. Definitely important.
Able
No
to
doubt
give
at all.
that is an issue, but definitely has a role.
Yeah, and if we see the patient actually in the long term, actually is quite helpful and quite significant actually. Later on, the patient, the vision gain, anatomical response, everything is quite better if you have given the loading dose actually.
To see your patients 2 years down the lane, diabetic
Yes,
patients, to see the patients whom you have loaded and if you have started PRN from the beginning, there will be a difference.
it's a difference actually. Okay. I think.
Yeah, I think it's
Dinner
a great
time.
discussion. Yes. So you can move to other like audience if there's any questions.
Sure.
We can address that
Yeah.
as well. Okay. If no, I think everyone is hungry right now. So it's already 9:39, over 9:30.
Sorry, because of me. Extremely sorry.
No. It's okay, sir. It's the discussions will going on and
Next আমরা কবে meet
ultimately-
করছি স্যার?
Sir, thank you.
And because of the technical glitch, there is also a
It's
delay,
okay,
sir.
it's okay, fine.
So anyway,
I think আমরা next week meet করব স্যার, তাই তো? সুদীপ্ত স্যার?
Next week কোথায় এতে?
ওজুডেক্স একটা মিটিং আছে না মনে হচ্ছে?
Correct.
24 তারিখে মিটিং আছে দেখছিলাম।
Date 25th, I think.
20.
Okay, Abhishek.
Yes, sir. So, thank you, sir. It was a wonderful discussion. It is really helpful for our audience also. Nowadays, many doctors now they are also their individual clinic. They are practicing the anti-VEGF. So this kind of discussion really help them to treat their patient and enhance their knowledge. So obviously, for the benefit of the society, benefit of this group of doctor, and for you also, and again very soon we will plan this kind of meeting for the next month also. Sir. So thank you, sir. Thank you everyone for your valuable time, for your presence, and
Thank you, sir.
Thank
And
you.
good night, everyone. Good night. Good night, Sudipto sir. Good night. Dear.
Good night, sir.
Good night, sir. Good night.
Thank you.
Good night.
So now I am requesting technical team, please log off this